Good evening, everyone, and thank you for joining us and spending part of your evening learning about CAMBRA and how it can help your patients in your own practice. We're really excited tonight to spend some time talking about implementation and the progression of the CariFree system. Before we get started, just a few housekeeping items. First, you are all muted, so we can't hear any comments or questions verbally. Please make sure to type questions into the questions box on the right-hand side of your screen. At the end of the presentation, you'll have a few minutes to enter questions. We will do our best to get through as many as we can. Any questions that we don't have time for will be addressed via email, and we also offer one-on-one webinars for practices interested in learning more. And lastly, you should have received an email with a webinar handout to help you define your CAMBRA protocol. If you don't have the handout, you can find it online by going to CariFree.com. On the dentist side of the website, go to Learn, Webinars, and click on Webinar Schedule. From there, you can download a copy of the handout. And with that, I would like to go ahead and introduce Dr. Kim Cooch, CEO and founder of Oral Biotech and the CariFree system. Dr. Cooch has been successfully practicing dentistry for over 30 years, still practicing 3 days a week here in Albany, Oregon. He has a huge vision for curing dental caries, motivating him to start his company. And he continues to motivate him in the research he's leading to improve caries diagnosis and treatment. He has a lot of passion for what he does, and it's always great to hear him speak. So with that, Dr. Cooch, take it away.
All right, thank you so much. And welcome, everybody, tonight. I'm really excited. This is our third part of our three-part series on implementation of CAMBRA and really creating that protocol for yourself in your own practice. So we've got the remaining topics to go through tonight, and so this has been a really fun series for me, and I think for the team, really to look at what kind of issues, what kind of decisions do you need to make each step along the way in setting up that protocol in your practice to make it look the way you want it to, and to be able to do it successfully. So with that, I'd like to jump right in here tonight. And my mouse is not advancing. Hang on. Here we go. I've got a brand new computer here tonight, so away we go. I want to just do a quick review of what we covered in the last topic. We really went through therapeutics, and we looked at the different materials and that you might, or the different approaches that you might take to address therapeutically treating dental caries as a disease. And number one, obviously, on that list is and will be for a long time, will be fluoride. We really look at pH and elevated pH to change the behavior and modify the makeup of the biofilm. Xylitol is an anti-caries agent, remineralization, and then also antimicrobial type therapy. So, you know, we reviewed those in terms of how you might apply those based on the disease, the risk factors that your patient has. One thing that I want to bring you up to date on, this was just published, if you didn't see this was just published last month in JADA, and the Council on Scientific Affairs from the ADA just published a new executive summary on recommendations of fluoride use for topical fluoride for caries prevention. And so they did this in 2006, and we've been kind of following those guidelines and protocols for 7 years. And they just published an updated version of that. So if you haven't had a chance to read that article, I think it's worth a read. It doesn't change much over what we're currently doing. There's only one change, and that's on the middle of the page here, the fluoride rinse. Of a mouth rinse of 0.09%. We've been using a 0.05%. That's pretty much been the standard. And I'm not quite sure yet what to make of this. I know everybody is kind of looking at this. The council went back and looked at studies. The references they cite for this are from 1965, 1971, I think 1976. They have a bunch of studies. Alice Horowitz's classic work from the 1970s, and then some early studies from the early 1980s. So it's been kind of a, they've looked at a lot of older research and came up with this, which really I think they intend that to be a 0.2% fluoride mouth rinse, which would end up with a 0.09% concentration of the fluoride ion. So that's the only change, and so I find that interesting. Beyond that, fluoride varnish is still our go-to for patients. You know, we see them in the office once a month. You know, for those high or extreme risk caries patients, every 3 months. You know, for patients at risk that you're going to see, particularly for children. And the other recommendation I would point out to you at the bottom of this, just using a fluoride varnish on children under the age of 6 was the only recommended use of fluoride, topical fluoride. So that varies a little bit from the American Academy of Pediatric Dentistry, who recommends an 1,100 part per million fluoride dentifrice for children even under the age of 3. And they determined, based on the research, that whatever risks there were in terms of fluorosis, the benefits in terms of caries prevention outweighed that risk. So that's a change just strictly coming from the ADA. So I present that to you to, you know, probably go back and look at that article. Certainly we're going to be evaluating doing some stability testing on increasing a concentration in a fluoride mass rinse in 2014. So that's from the Council of Scientific Affairs. You know, we talked about, you know, we primarily use 3 main products at CariFree as we are treating the caries active patient. Primarily the treatment rinse, the CTX4 treatment rinse, which is really has antimicrobial properties with sodium hypochlorite. You know, it has a pH, it's in the neutralization strategy. It has a 0.05% fluoride. It also is saturated with xylitol. The CTX4 Gel 5000, which again has 4 strategies as well, it has nanohydroxyapatite instead of an antimicrobial agent, so it's more for that long-term therapy, particularly, you know, adding a remineralization strategy to it. Then we've got your 0.05% type fluoride rinse in the CTX3, which also has xylitol and a pH of 8.0. So those are the kind of products we looked at. Now we have those, that we put those in kits. And one of the things that I talked about in our last webinar was if you're going to use products, you really, what I started doing, you know, 13 years ago was handing the patient, you know, 1 bottle of this and 1 tube of that. And of course, at the end of the month, they'd run out of it. I wouldn't see them for 3 months, and we'd be starting all over again. And I did that over and over until I thought, this is stupid. I need to give the patient a 3-month supply in their hands and have them take it, show them how to use it in the office and have them take it home, so that if I'm not going to see them for 3 months, at least they're not going to run out of product or, you know, therapy in the meantime. And so I think that, you know, however you approach kits, whether you know, make your own out of products that you like, or whether you use the CariFree kits or whatever you do, I think it makes sense to put 3 months worth of product in their hands, particularly so that it meets your recall schedule. And you know, so that makes the most sense to me. And certainly in the kits that we have, we try and provide the patient with, you know, product instructions, what to expect, what else they can do, what are the other risk factors, you know, how they look and evaluate products that they're using, and, you know, other just suggestions for them. But one other thing that I would share with you is that they estimate, this is a report, this came from, I think this came from the CDC, about 50% of the prescriptions that are written never make it even to the pharmacy. So in terms of compliance or adherence or participation from our patients, and I think you guys know this, I mean, I hear this all the time. I write a prescription for antibiotic, you know, I see the patient a week later, no, I didn't fill it, no, I didn't take it, you know, so frequently, you know, we'll make a recommendation to a patient, and if you're handing them a prescription or saying, go to this website or go here, go buy this at the drugstore, more often than not, the patient probably isn't going to follow through and do that. So we have much better compliance by actually being able to hand the patient the product, whatever you use, show them how to use it, get them started with it in the office. I think you have a better opportunity to have participation or success on the patient's part by doing that. So question number 10, if you pull out your handout, and question number 10 is, you know, are you going to use kits, or are you going to put together your own materials for kits? And so again, based on the information I've shared with you, you know, you can use, your options are you can use pre-made kits, A, B, you can put together your own kits. C, you can, not use kits at all, but just use individual products. And I would tell you, encourage you, whatever you decide to do, I'd like to reiterate, try and give the patient 3 months supply at a time. And secondly, try and put it in their hands. I know it's kind of a pain for us to stock product and do it that way, but you're much greater likelihood that you're going to have success with your patient if you physically put that product in their hands versus depend on them to go source it for themselves. So again, we come to a point where you just need to pick one, and I don't care how you approach that. Tonight, and we've already had a bunch of questions at CariFree today on the new CDT codes. So the next section here is we're going to go through the CDT codes that I think apply to CAMBRA, talk about them just briefly, and so you'll have a list of these. The DO415 is oral evaluation and consult for a patient under the age of 3. So certainly if you've got a 1-year-old or a 2-year-old patient and you want to talk to mom, they're high caries risk, and you want to consult and talk about their diet or what other risk factors that they have and how you might want to design some therapeutic strategy for the patient and the mother, certainly I think that's something that you should be paid for. So we have a fee code for that. Now, understand that your patients may not have, depending upon their plan, they may or may not have coverage for any one of these fee codes. The next 3 or 4 fee codes basically are diagnostic fee codes, collection of microorganisms. If you were going to be doing bacteriological testing, if you're going to be culturing, you may use some of these fee codes, the DO415, 147, saliva sample. Certainly if you were doing buffering capacity or if you were measuring saliva flow, that would be a good fee code to use. The DO148, analysis of the saliva sample. The DO421 is genetic testing for susceptibility. Primarily we use that for, periodontal testing, and I think based on the number of studies that have been published in the last 3 years on a variety of sources of genetic susceptibility for dental caries, I think that at some point down the road we may end up with a test that we can use, somewhat like the periodontal interleukin 1 and 2 test, 1A and 1B test that we use. And then we've got, obviously your Pro-Fee for adults and Pro-Fee for child, topical fluoride for children and adults, the D1206 fluoride varnish for a moderate to high caries risk patient, an off-label use of fluoride varnish. That fee code's been in existence, I think, for 4 years now. I'm thinking off the top of my head. But certainly that's a fee code that most of the plans that you see should cover that. And you've got the 1310 nutritional counseling, 1320 tobacco counseling, and 1330 oral hygiene instructions. Those really, we're going to talk about some behavioral management tonight. We're going to talk about wellness coaching. And so these are really behavioral strategies that are potentially modifiable, theoretically modifiable. It's just challenging to make behavioral changes with our patients, and that's where really a skill like wellness coaching comes into play. But those are fee codes that you might use in a behavioral strategy. Obviously, the 1351 sealants. The 1352 is a fairly newer fee code, preventive resin restoration for the moderate to high caries risk patient. So this is kind of that no man's land, that gray area between is it a filling or is it a sealant. You've got this high caries risk patient. They've given us a fee code now for preventive resin restoration. Again, a newer fee code that you may or may not find coverage for with your patients depending upon their insurance plan. Other drugs or medications by report, the 9630, 9920, behavioral management by report. Again, you might use that for a wellness coaching fee code. Enamel microabrasion, if you're, doing some, enamelplasty, removing some white spot lesions that you're then remineralizing. And then these are the new fee codes that we discussed a couple of times this year already, but these are ones I think that everybody has questions about at the moment, and you've got your DO 601, 602, and 603, which are caries risk assessment for with a finding of a low caries risk using a recognized assessment tool. And so that's kind of the language. And so, we talked about earlier, I think in the first webinar, I showed you 4 different Caries risk assessment forms that, in my mind, certainly are validated or valid risk assessment tools to use. And then you've got the moderate Caries risk finding and the high Caries risk finding. So those are codes that are new this year. They're coming out in January. So you may or may not find coverage on your patients immediately in the short term, but I think that you're going to see the insurance companies creating insurance products for employers that provide coverage for this. There's a lot of excitement in the insurance industry about Caries risk assessment and how it's certainly going to provide, hopefully, better treatment outcomes and reduce costs, to the system for everybody. Anyway, so that's those are the new codes there. So the next question that you need to make a decision on is, when are you going to present treatment? And I would tell you that, as you make a recommendation for, here are the risk factors that we see, here are some of the strategies, and you try and engage the patient, into the process, ask open-ended questions using some of your coaching skills. At what point in your appointment are you going to start talking about, here's something that, here's some recommendations, here's some options, things you might consider, here are things that you could do to improve your health and reduce your risk for getting cavities, and, talking to the patient in that kind of language. You can do that at the start of the appointment, kind of during the exam, or at the end of the appointment. And I would tell you that I've done all 3. At the beginning of the appointment, making recommendations, kind of at the outset before the patient really has time to absorb the information that you're sharing with them, what your findings are, and having a conversation about that, I think is maybe a bit early. And I think that practices certainly that have tried that, some of the feedback I've had from practices that have tried that, they went and did the testing, did the risk assessment form, and sat down before they discussed anything else. They discussed their Caries strategies and management. And the patients really, kind of the feedback was, I felt like this was such an abrupt change in how I'd been treated before that I felt like, they were just trying to sell me some product. I really wasn't engaged in the process. So I would tell you that that's an option. Probably not the one that I would pick. If you do it during the exam, we tend to kind of, in my practice, the way that we do this is the hygienist, the patient fills out the risk assessment form before they come to the hygiene operatory. The hygienist reviews that with them, creates whatever findings that they find while they're working with the patient, discussing and educating the patient, which is hygienists are incredible educators, educating patients about risk factors and about what causes the disease. And then during the exam, when I come in, we have the conversation that the hygienist and I and the patient kind of as a team kind of sit and have this conversation about, this is what we found, what would you like to do? How would you solve this? What kind of options do you think that you would be willing to make and changes and what? And we kind of have that conversation kind of during the exam. So kind of at the end of and that typically happens toward the end of the appointment. So the hygienist and I get to, discuss with the patient and make recommendations. I might make recommendations to the patient that then the hygienist can follow up with and have a more intense or more involved conversation with the patient and answer their questions and kind of continue the whole coaching conversation maybe after I leave. So really I would say during the exam or kind of at the end of the appointment would be something that I would recommend. It may be kind of a hybrid between the two in your practice depending upon when you do your exams, how much time you spend, and how much time is left after that the hygienist spends with the patient as well. So again, we come to a point where it's take out your pencils, take out the worksheet, and pick one. And again, I'm not invested in whichever one you pick. I can only just share with you my own personal experiences and experiences with practices that I've gotten feedback with patients or practices that we've worked with over the years, trying to perfect this so that it works better for everybody. So pick one. And then the next question is, how will you present the therapy? And again, this may seem like, okay, well, what does that mean? Well, it really comes down to the concept of, are you going to present one recommendation, like you really need to do this, or I would recommend that you do this, follow this therapy, here's the protocol, here's the regimen that I want you to follow, this is what I would recommend that you do. You might be even more forceful and say, this is what you need to do, or here's what you should do, or whatever language you would use. You can present one strategy, or you can present options. And one of the things that we know in dealing with human behaviors is that when patients or people are given options rather than one choice, take it or leave it, this is it, when they're given options, more than 50% of the time they choose to do something, choose one of the options rather than choosing to do nothing. So if you've been presenting, therapies and strategies, and you haven't had a lot of success with that, I would think about presenting some options. Okay, this is what I would ideally recommend, but short of doing that, here's another option. And certainly when you're dealing with a patient that, when you've identified the usual suspects, you've identified the risk factors that they have that are driving the disease, and it may be more than one risk factor, or it may be dietary, and it may be 2 or 3 dietary issues that you're trying to discuss with a patient. I don't try and make all those changes at one time. I try and engage the patient and get them to make the decision on, here's what I'd like to change, here's what I want to do, here's what I think that I would be successful at, here's what I want to do first. So recognizing that we need, there are a number of things that we have to do here. We don't have to do it all at once. And I used to be really invested in telling the patient, we need to do this first, that second, that third. I would phase the treatment, I would phase everything out, and it was like, it was my way. And at some point, after I got through my wellness coaching program, it was, that was the wrong approach for most people. Better to ask them how they would like to do it. Here's 5 things we need to change. We're going to start with one. Rather than me tell you which one I think you should do, which one would you like to do? Which one makes the most sense to you? Because that's where you're going to find the best participation. And if they have success with the first one, more likely that they're going to attempt to make the second change and have success with it also. So, how do you present the therapy? Are you going to provide any options at all and just tell them to go do an internet search? So I would tell you, really, we're talking about giving the options, like from a guide. Here's some different options that we have here in terms of therapeutic strategies, or you can just make one strong recommendation. And again, I leave it up to you. So it's time to get your pencils out. This is one of those decisions that you need to make, and pick one. So I'll give you a second here to kind of think about that. And I have to tell you that this may seem kind of pedantic or trivial, but we did that multi-site study looking at risk factors on 6 different practices, and one of the metrics that we measured was the success rate at patients participating and choosing to do something. And it was significant on the practices that had a fairly low percentage of patients participating, weren't giving the patients as many options, let's say. So it's interesting that that behavioral component, given choices, people are more likely to do something than when they're not given a choice. So I'll share that with you. So, we've talked about, diet and home care. Those were a couple of the fee codes, and tobacco counseling. Tobacco, I think, probably plays a bigger role in periodontal disease than it does in dental caries, but certainly, again, that's something that you may want to do for all of your patients. Anyway, so we look at wellness coaching, which is rather than telling people what to do, we have told people they need to floss. We can tell people that they need to floss until we're blue in the face, and that doesn't make people floss. So we really need to engage them in the process and get them to understand how making that behavioral change may provide a benefit that is something that they want, and then kind of help them get specific on how they might make that behavioral change. So really, the wellness coaching is part of the conversation here. I was trained by Ferocia Knight. She's a world-renowned wellness coach at the Baraka Institute in Portland. Ferocia has actually created a wellness conversation specifically for dentistry. So I'm going to share a little bit of that with you tonight, but if you want to learn more about wellness coaching, I couldn't recommend anybody better than Ferocia. In fact, she's training my entire office team. So Ferocia's come up with a 7-minute coaching conversation. Actually, once you get experience with this, you might even get it down to 4 minutes. And I know that one of the things we struggle with is, how am I going to do coaching with my patients? I don't have time. I don't have time to coach them. And what Ferocia really sat and analyzed, spent a lot of time looking at dental practices, spent a lot of time with hygienists, looking at the conversations that we were already having with patients, and realized we're already taking the time to talk to patients. Let's change the nature of our conversation to make it more coaching-like. So it's not like I need now an extra 15 minutes to do wellness coaching. I need to weave the coaching language into the current conversations that I'm having with patients and learning the skills on how to do that. And so she's really taken it down to a 7-minute conversation. We're incorporating those concepts into our practice. We've been doing that for the last almost 3 years now. But number one is envision the patient as a whole, complete human being, and so that you're not sitting there looking at somebody that you see as ineffective or incomplete or not capable or not competent, because that affects the outcome. So being able to look at a person and say, I see a whole person here who is suffering from this disease, but they're a whole and complete person and they're capable. Educating the patient on what you see rather than telling them, you need this or you need that. We always go from what we see to how to fix it, instead of engaging the patient in the process by helping them understand what's actually happening in their mouth. And not being judgmental about it, just reporting those findings, sharing those findings with them so that they can be educated, informed consumers. Enrolling them, getting them involved in the process, in the decision-making part of that, and then empowering them. I mean, it's like empowering them, it's like you become part of the process. This is your health. Here's 5 options. Which of these do you think makes sense? Which of these would you like to work on first? And then really engaging them and helping them get started, like, okay, so logically, what would you do first? How would you go about creating that change in your life, and getting very specific about how are you going to do it? At what time during the day? What's your plan? Helping them develop trigger mechanisms so that it's like, oh yeah, when I do this, I'm going to remember that that's when I change my behavior, so that they can get that behavioral change and be effective. And literally just taking those concepts and weaving them into our current conversation doesn't really increase the amount of time that we spend with patients. It just makes our conversations more effective with them so that we can be better. And part of that is asking open-ended questions. How would you do this? What makes sense to you? What do you want? Rather than, we ask patients if they floss. Well, everybody knows the correct answer to that is yes. And how many times you ask the patient if they floss, and they don't floss, and yet they say yes. And, then we ask them, well, how many times a day do you floss? And, everybody knows the correct answer to that question. And, I love the one physician who was totally honest with me and said, Kim, I floss twice a year, right before I come in to see you. And it's like, and that's the reality for a lot of patients. But, telling them that they need to floss, and telling them over and over and showing them how to floss doesn't get them to make a behavioral change. And so, really asking them questions like, what's important to you? What would you like to focus on? Why are you here? How can I best, be the dentist that is going to be successful for you? What does that look like? And if it comes down to the changing things, what would you be willing to change? How would you benefit? Always it's important for the patient to understand and appreciate their benefits. Again, if we know what the benefit is to us when we're trying to make a behavioral change, and you can think about your own life and changes, whether you've tried to lose weight or, stop drinking Diet Coke or stop smoking or whatever it happens to be, or start flossing, whatever the change is, maybe a nervous habit, whatever, always being clear on the benefit. If I do this, I know that this is the benefit, and that's important to me. And always being clear about what that benefit, it helps motivate us. And then one of the phrases that I use a lot in my practice, and that I share with audiences all the time when I talk to them, is tell me more about that. Be interested in your patients. That's interesting. Tell me more about that. It's not judgmental. And so, you know, when people ask us questions about us and they're curious and they're interested, we open up and tend to provide those answers or talk more freely about that. So I think, you know, it's easy for us to get into kind of the judgmental, you don't floss correctly, that's why you've got these cavities, you're not doing it right, here's what you should be doing. And no matter how we try and phrase that, it still comes across as kind of condescending to patients and judgmental. We hear that from our patients. And so if we can change our language to be less judgmental and ask more open-ended questions, certainly this, I have to tell you in my practice, this has made me a lot more effective as a dentist and as a person and as a coach. So those are just some phrases I would share with you. When we talk about behavioral changes, the two biggies, you know, the usual suspects, the two biggies under that behavioral problem is typically diet and home care. And, you know, so I just want to share a little science with you. This was a study done on children between the age of 3 and 5 years. I know it's a public health study, and I think that it was kind of shocking to me because, you know, Dana and I are quite health conscious, so our children, our grandchildren are raised on pretty healthy diets. And so, you know, you project out into the world that everybody has that kind of concern and care. And they found in the study that more frequent toothbrushing, greater milk consumption at meals, and avoiding pre-sweetened cereal at meals reduces the risk of developing non-cavitated caries. There are a lot of children in the United States that eat breakfast cereal for dinner. I mean, cereal is 70% sugar, refined sugar. They're eating this for breakfast, and they may have some kind of other meal at lunch at school, and they come home and they eat they eat a couple bowls of cereal for dinner. I mean, that was kind of an awakening for me. I didn't really think about that, but when you think about diet and caries risk, I mean, having that kind of sugar consumption during the day, and that happens to a lot of our children in the U.S. So that's just something I wanted to bring to your attention in the study. Certainly it makes sense. It was just kind of a surprise to me, the amount of cereal consumption that's happening beyond the breakfast hour in this country. So it certainly increases their risk for dental caries. Sodas, even diet sodas, you know, in this study it was really looking at erosion due to the abuse of drugs and particularly things like methamphetamine. But even acidic carbonated beverages. So, I mean, you know, you look at, if you're not drinking water, whatever it is could potentially, that you're drinking other than water and even water, as we discussed, I think, in the first webinar, even water could be harmful because about half of the bottled waters are acidic in the range of 4.0. So you really have to be kind of conscious of or aware of what you're putting in your hand that you're sipping on or drinking during the day. And the same for patients. You know, carbonated beverages, if I can get a patient to switch from Mountain Dew to Diet Mountain Dew, that's a huge victory in our practice. I mean, it's a baby step. I still want to get them off of the Diet Mountain Dew, but expect them to just quit that altogether, that's a huge behavioral change for somebody that's maybe drinking 2 or 3 big gulps of Mountain Dew every day. So it's like we want to make a program for the patient that they can be successful at. But certainly even at the best case scenario, these diet sodas are leading to erosion as well. So diet soda is an issue. And then this was a study that was published earlier this year, which I thought was really interesting. And going back to Alice Horowitz's studies from classic studies from the 1970s, where they did supervised brushing and flossing interventions in school children, and found that really brushing and flossing had almost no outcome in terms of the caries rate on school children. And so this is in the 70s. You know, and there hasn't been, I have to tell you, there hasn't been a lot of data that indicates that, you know, brushing and flossing provides this huge benefit. Now, we've seen a couple studies in the last few years, particularly there have been a couple studies on flossing that indicated there's a benefit, but we went for a long time without a lot of data. This is a very interesting study. It was done on preschool children, and they started in Scotland. There was 99,000 children in this study, so it's a huge cohort, and it followed over a period of, it was a longitudinal study of 22 years. And what they looked at was the caries rate by teaching children in preschool how to brush their teeth would it have an impact, in the following 10 years of their caries outcome? And what they determined was they had reduced their DMFT from 3 down to 2, which is hugely significant. So by teaching, these preschool children how to brush their teeth at school, it actually demonstrated that toothbrushing has a pretty significant reduction of the DMFT scores on these kids as they get to be 10 and 12 years of age. So nursery toothbrushing, I think this was a pretty exciting study, and so I think you can depend on that data. There's been a lot of evidence in the last year or two, primarily on sugar and the addictive factor of sugar, refined carbohydrates. And I know that I'm going to bring up a couple more of those studies here right away, but this study I thought was particularly worth notice. This was published in the Evidence-Based Dentistry Journal back in June of 2012. Well, what they determined in looking at behavioral change around sugar was that it was actually, sugar is so addictive that it was actually easier to change behaviors around alcohol and fruit and vegetable consumption than it is to change somebody's sugar dietary behaviors. So I want that to sink in for a second. It's easier to change somebody's alcohol issues than it is to change somebody's sugar issues. So when we talk about changing and making dietary, modification of behavior and recommendations for patients, if they're addicted to sugar and they have a high sugar intake, this is not something that's going to be easy to change. I mean, out of the gate, recognize this is harder than changing somebody's alcohol behavior. And then, of course, these other studies, which I'm sure you've seen on the internet, you've seen on television, this one found that sugar was the neurological level, the response, the sugar and sweet reward are more robust than those of cocaine. And that may be an evolutionary thing that, drove us toward, intaking calories when we, when we had the opportunity, to survive the lean winters or whatever. But it's more addictive than cocaine. And then this study certainly looked at this next study, which I think you've probably all seen or heard this fall. But this was at, Connecticut College, and they looked at with rats that Oreo cookies were as addictive to the rats as cocaine. Given the choice, these rats were choosing Oreo cookies over cocaine. So, certainly this brings up a tie, and it isn't, I don't want Oreos to have a bad name here, a bad rap for anybody that loves Oreo cookies, but it's really what we're still talking about is the sugar. And it's just, I think for us being able to comprehend how addictive sugar is, and certainly dietary issues with sugar can play a major role in dental caries. I think it's probably it is one of the major factors in the United States in general in our caries rate. As we look at the amount of refined sugar that Americans consume, and I've reported that early in our webinars. But certainly, I mean, this is stuff for us to stop and look at. So next step in this whole protocol then is delivery. And we need to look at fees. What are we going to charge for the products? And if you've got kits, or if you're using CariFree kits, or kits that are already pre-assembled, you can use the recommended retail pricing on that. You can create your own price. You can charge more. You can charge less, or you can charge wholesale. I mean, I have a lot of practices that don't feel comfortable selling product. They sell everything at cost to patients. I don't have any problem with that. But I also don't have any problem with profit is not a four-letter word either. So, as patient or practices are asking, how do we want to do this? It's the right thing for the patients. This is something we feel strongly about. But how do we stay profitable by doing this? So certainly, selling some product in your offices certainly adds to your bottom line. So again, you can go with recommended retail pricing, which I feel very comfortable with. You can go create your own pricing. You can go with wholesale pricing. It's strictly up to you. And I'm not emotionally invested in what you choose either here, but certainly pick one. So give you a second to kind of think about that, how you want to approach that. But I think it's important to, again, as part of your protocol. And then I have patients that I have to tell you in my own practice that I routinely And if I can't, if I won't have a patient that wants to participate and, should make a decision and do this, I might even put a tube or a bottle of some product in their hand and just say, you know what, I'm giving this to you. I want you to go home and try this. I just want you to try it. Take it home and substitute it for what you're currently using, and it's, I'll give it to them. So I just want patients to get healthy. And so next question is, where are you going to dispense the product? And so I have practices that, dispense product in the back office. Your other option is really to dispense the product in the front office. And I'm not, again, and you may choose not to dispense product at all and have patients force it themselves. But if you're doing it in your office, you really have those two options. And, I would tell you, I think it's more successful to do it in the operatory, to dispense the product for the patient before they leave, discuss pricing or whatever about the product at that point in time. You need to do that. But certainly, I think it's important to do it in the operatory, and maybe if they're going to use something like the treatment rinse, to actually mix it up for them, have them use it once, prepare them for the taste and, the experience, and show them how to do it. Again, more successful than just handing them, sticking some in their hand and say, here, go home and use this. Get them engaged in that process and help them with it, and get comfortable with using it. See, it's just like a mouth rinse, or this is just like a toothpaste. You just go home and here's how much you use, and go ahead and try it, and talk to them about it. Kind of be participate in that process with them. But again, you can dispense product in the operatory at the front desk, or not dispense it at all, and depend on the patient again. So that's up to you. Pick which one you want to implement in your practice. Reassessment is next up, and one of the things on reassessment is how frequently you're going to see the patient. One of the questions I typically get is, how do I know when to see the patient? When do I know, how often or how frequently do I need to see them? And some of that's going to come based on your experience in treating these kind of patients. I would tell you that for the really highly active caries patient, you're going to be treating their lesions in the short term, so you're probably seeing that patient at least once a month. So that patient in the first 3 or 4 months while they're in active restorative therapy, as well as therapeutic strategies or behavioral strategies, I'm wanting to touch base with that patient about once a month, make sure that we're on track, check in with them, see if there's anything else I can do to support them in terms of making whatever behavioral changes they're doing or trying to attempt to make. Just seeing how the whole process is working for them. For a patient that is maybe I've got the lesions restored now, but they're still active or they still have a high ATP score, I'm still concerned about them, they're still working on behavioral changes, I'm looking at seeing that patient every 3 months. And I would tell you that making the behavioral change, I know that we've had these, the idea or the thought, I know you've heard the quotes, you can create a new habit in 28 days, or you can create a new habit in 21 days, and the best data is coming out of the Cleveland Clinic from the wellness program there, is it takes about 9 months to make a behavioral change and have it stick. So you can make a change, and you see this happen all the time. This is what yo-yo dieting is all about. You can make the behavioral change and adhere to it for 3 or 4 months, and then 3 or 4 months later, you're back to square zero. Maybe you've actually gained more weight than you lost in the first place. Then you go back and you try a different diet, and then you lose again. But it's like it doesn't stick. And so to really create a behavioral or lifestyle change that sticks and is sustainable, that doesn't happen in a period of 21 to 28 days. It takes 28 days to develop a new habit, and it takes about 3 days to lose it. So we really need to participate and help this patient understand this isn't going to happen overnight. We see continued improvement in ATP scores in therapy for about 2 years. So when I started into this, I thought it was going to be like a 30-day process. Wham, bam, we're in there, we hit it hard, we treat this disease, and boom, they're cured. And this is more of a slow, gradual, but I want it to be sustainable lifestyle and behavioral change, and understand that may take this may be a couple of year process. And you know what? I don't care if it takes 2 years. but I can get that patient healthy. I don't care how long it takes, and it's incremental. As long as it's sustainable and it's working, we're making progress. That's what I'm all about today. I don't have to solve this thing overnight. So in terms of recall and how often do you reassess the patient, every patient in my practice gets a risk assessment form to be filled out once a year, and I'm screening them with the biometric, the Cari screen, once a year. And I think it's really important. I know that people are doing this just like sporadically, and it's like, well, I'm using this abbreviated risk assessment form. It only has 5 questions, and if they say yes to 3 of them, then I'll use the biometric. And that's all well and good, but I have to tell you, if you really want to treat this disease and have outcomes, that is not going to cut it. So you're going to need to risk assess some patients at least once a year, and you're probably going to want to do a biometric once a year on them as well. So the question I've got, number 17, and it's been on the screen here for you. How would you implement CAMBRA in your practice? How are you going to go about this? Like I've kind of shared with you the decisions that you need to make, the parts of the protocol that you have different options on how you might do it in your practice, what it might look like. But the question I've got for you is not how I did it, but really how would you implement it in your own practice, and how would you solve this? And you might recognize those questions as being coaching type questions, right? But really that's what this is about. How would you do this? Because for me to tell you, it's the same concept. For me to sit tonight and tell you, I can make recommendations, which I did tonight. I shared with you on a couple of those. Here were my experiences that were positive with this option. Here are the experiences I had that were negative with that option. I would encourage you to do this, but you can choose any one of these 3 options, and I'm not emotionally invested in whichever one you choose. It's more important that you choose the one that fits for you, but I want to make sure I share my experiences with you on how it worked for me, but I want you to make that decision on how you do it. It's important not for me to tell you what to do, but really you're going to be more successful if you can implement this and have a picture of how you want to go about it in your own practice, like how would you solve it. And one of the most important parts of strategic planning, whether you're talking about your patient and their caries management, or your implementation of creating a protocol for CAMBRA in your practice, what's your any strategic plan? What's your timeline for this goal? If you don't have a timeline, we can't stop and look and take an assessment and go, okay, we wanted to have this accomplished by, June 30th of 2014. I want to have this completely implemented. If I don't have that time frame out there, it's less likely that I'm going to be successful in ever getting there. So if I have that time frame, I can stop and go in February and go, okay, so here's my goal. Here's how far I am. Is that goal still realistic? Am I ahead of schedule? Am I behind schedule? So that you can reassess and make changes as is appropriate so that you can meet your goal. The same thing for your patients when you're talking about whether it's behavioral changes or therapeutic strategies or even restorative therapy. If you've kind of got a long-range plan and you've got a blueprint that has a timeline on it, we tend to be more successful at accomplishing our goals when we have a timeline that we've committed to. So again, I would like you to sit down and think about what's your timeline for this, for setting up CAMBRA in your practice, when do you want to have it fully implemented. And really I can see breaking it down into, if you want to break it down into steps, you don't want to do the whole thing all at once, start with the risk assessment form. When do you want to start that? Implementing a biometric, when do you want to start that? And implementing then your therapeutic recommendations. I think you get to the point where you've got the risk assessment forms and you've got the biometric, you kind of want to be somewhere along the pathway of having some therapeutic recommendations in place. Because to tell the patient they have these risk factors and they have this disease and then not have a solution or options for them available to them, would be frustrating for me as a patient. Okay, I've got this, okay, this is wrong, but now what do I do about it? Like, I want to do something, help me, tell me, help direct me, what do I do, where do I go, what kind of changes do I make? So you can do it incrementally. Those are the 3 steps. But again, or you may want to kind of tackle it all at once. On the other hand, that's kind of it's a big task. But I want you to pick and write down a timeline for yourself. I would tell you that trying to implement this all in, in 30 days can be done. Giving yourself a little more time, 3 to 6 months to really implement this and have it be thoroughly implemented into your practice. You might want to start with the high-risk patients and work your way into everybody. But anyway, those are the options that you've got. But circle the date on the calendar. Pick that date. If you've got, if you kind of got that in your mind, write it down. Write it down now. It's on your worksheet. It's on your blueprint. So pick your date. And then you need a launch date. When am I going to start this? So, I think obviously January 1 is rolling right around here. January 1 might be a good date to launch this. Monday might be a good date to launch it. But whatever you pick, or February, whatever it is, again, pick a date. So I want to launch this. This is my launch date. Here's what we're going to launch on that date. And here's how long my timeline is until I want to see this completely implemented in my practice. Now, this is really an important concept, and this is Dave Logan. He was a keynote speaker at the COI Symposium this last year. He'd written a book. He's at Stanford in the economics department. He'd written a book on tribal leadership. And the concept is that we as human beings form tribes. And you look around you, and you look at organizations, and you look at businesses, you look at everything. You look at family, core family units. You look at this, and we form tribes everywhere around us. And Dave's premise was that in terms of leadership within the tribe, that we are most effective as a group of 3 people. It's the power of 3. And so it's like having 3 people where you always have 2 people that have your back. You and another person always have that third person's back. And if there's ever a dispute, it can be somewhat democratic. 2 people can help convince the third person, if there's a dispute, 1 person can step in between 2 parties and then also act kind of as the mediator, so that we are most powerful as a small tribe and leadership of 3 people. Now, I have a tribe here at CariFree, and and we go in to look at the business and entrepreneurial world. I can tell you what those 3 members of that triad, who they are and what they look like. In your practice, I would tell you that I ended up doing this accidentally years ago. But I had 2 other people on my team that when I started, we formed a triad, the 3 of us. It was really important. This was a goal. This CAMBRA was a goal for the 3 of us. Now, we were working in a team of 20 people, but for the 3 of us, this was really important. It was something that we wanted to accomplish. And when I was trying to push this ball by myself and trying to make this change in my practice, I felt after a couple of years like I was beating my head against the wall. And it was a real challenge to make this happen in a team. Even when you are the leader, the visionary, the person in charge, it's still, if you're on there, if you're trying to make that by yourself, it's a challenge. You're whipping the slaves, trying to get them to do something. But as soon as I enrolled 2 other people and we became a team of 3, it was like suddenly everybody else wanted to know what we were up to, and they got more interested in it. And just the power of having 3 people engaged in something and trying to make a change, it really changed my practice. And it changed it in a span of a year. We implemented all of these kind of concepts throughout the entire team. So really having 2 more people on board with me forming that triad made the difference for me. That was like the tipping point. So I would tell you, in your practice, who are the 2 critical people that if you had on your team to implement CAMBRA, that they embraced it and they wanted it, saw the benefit, valued it, and wanted to create that in your practice, who would those other 2 people be on your team? And I know that you know who they are. I mean, I literally could tell you I can tell you off the top of my head. It doesn't take any time at all to tell you exactly who those 2 people are in my practice that I need enrolled to help me make any kind of change. And once those 2 people and I have a triad, it will be successful. So I want you to identify right now and write down those 2 names, because the 3 of you are going to form a triad for CAMBRA in terms of implementing this. Maybe if you have a team, if there's only 3 of you in your practice, boy, you guys are going to rock. But, if you've got 5 people, still form a team of 3, and you'll be amazed. And you might want to read the book as well. But name those 2 people, identify them, And so then more coaching questions for you, but this is really, okay, so now you want to do this. You've made a decision. We have a launch date. We have a target date. I've identified my triad. You know, what is your first step? What are you going to do first to get this program started? And I can tell you what I would do, but it's really up to you to figure out, you know, what your first step is going to be. In my mind, my first step was to take those two people out to lunch, share with them my protocol, my vision for what this looked like, and enroll and engage them in the process. Get them to participate and want to be a part of that team, see and understand the benefit, and become a part of the triad. So for me, it was really enrolling those two other people onto my triad to get this thing to go. I did it over lunch. We went out to lunch, and we started meeting weekly to talk about how are we going to do this and identify all of those steps and the things that you've made those decisions already on. But whether you do it at lunch or whether you do it after work or however you do it, however you as a group, you may decide to do it all at a staff meeting and talk to the entire team about it. And, you know, that's really up to you. But I want you to write it down, like what is your first step? I want you to write down what that is. And then the next, question number 22, is what will trigger you to remember to do that? So it's like identifying a trigger so that every time this happens, I'm going to remember that this is my trigger for me to think about this differently. Now I remember I need, and you know, it may be that you got to write yourself a note and hang it on your, you know, your desktop at work, or put it on your steering wheel. I mean, I write pink notes and sticky notes and put them on my steering wheel so I remember stuff. But whatever that trigger happens to be for you, write down and identify your trigger so that I know that when that happens, I'm going to remember that this is what I'm doing first, and this is what I need to do. So I would share a trigger with you that I think is really interesting. Every time you say watch, which we are so guilty of in our profession, I want to watch this. I want to watch that. I want to watch, you know, the filling on number 12. I want to watch that incipient lesion on, you know, on the distal of number 21. I want to watch this. I want to watch that. We do this all day long in our practices. I mean, we're guilty as can be of saying watch over and over and over again. Watch is a great trigger. Like every time you say watch, I would propose is you think about this. Every time that you say watch, I want you to think about what could I be doing instead of just watching it? Is this a tooth I could remineralize? Rather than watching this incipient lesion, is this something I could talk to the patient about remineralization, about, you know, a behavioral change? Is this something that I could talk to the patient about instead of watching it, actually doing something? So that the watch becomes a trigger. So in my practice, when I say watch, my patients, you know, my hygienist, you know, I want my hygienist to ask me, when I say watch, I want you to ask, that's the trigger, I want you to ask me, what exactly are we watching, and what else might we be able to do about it rather than just watch it? So there's a trigger that I'd like to share with you there. So how does this work in my practice? We've gone through kind of 3 seminars now on, you know, kind of from the very first, starting with the risk assessment, you know, start going to diagnosis, going through the entire protocol. And in my mind, literally every option that you have that you needed to make a decision on to draw this blueprint for yourself, I tried to bring up to you in the last 3 webinars. So, you know, how does this work in my practice? It's really about understanding what's causing the disease. If I don't understand what's causing the disease, I can't help the patient get effective therapy to stop the disease. So that really ends up in more effective caries management with predictable outcomes and happy people. You know, when you get somebody healthy, I have to tell you, and they're decay-free for the first time in their life, and this happens for a period of several years, the change in that patient and just the entire atmosphere in your practice, it changes like nothing I've ever experienced in 35 years of doing this. And in terms of success and profitability, this is, you know, helping people get healthy is the best thing that you can do for your patients, and it's the best thing that you can do for your practice. You know, so I use a validated risk assessment form. I use a biometric. I use pre-manufactured kits, you know, 3-month kits. Got to my patients. Now, if you haven't read the balance book or you don't have a copy of it, I want to invite you to, you know, just contact CariFree. We'll be happy to send you a copy of this book. It's all about dental caries. Bob and I sat down, you know, last year with the help of Ashley and others, and put together all of the information that we have about dental caries and about caries risk assessment and all the risk factors and what all of that means to us at this point in time. Didn't talk about the specific protocols and how you would go about implementing in your practice. And so that was really the birth of that idea, was really this whole webinar series that we've just completed here. So, but again, if you want to copy the book, I'd encourage you to read it. I give this book to patients. So that's something you might think about as well, particularly the patients that are curious, they want more information. It's like I hand them a copy of the book and say, here, go home. Mark it out, yellow mark it, dog ear it, whatever you need to do, and bring it back with questions, and let's sit down and talk about it. You know, help me help you. So I want to thank you guys all tonight. This has been, like, I really, for me, one of the most enjoyable webinar series that we've done. We'll launch off in January. I'll probably do an update on the scientific literature on dental caries, well, you know, from the last 12 months. Take a look at that and kind of share with you, you know, where we see dental caries, you know, in our research, where that's headed. We'll have some exciting more webinars for you in all of 2014. I want to wish you all a happy holiday season. And I know that we finished right on time, and we have time for a few questions tonight. If I just want to share with you if what you've seen in the last 3 webinars, if you have more information, you would like a free webinar for your practice to coach you on how to do this, or if you want to learn more about the CariFree system, please contact us. We're here to help you. We're here to, you know, we're here to help you get on top of controlling this disease for your patients. So I want to thank you tonight. So I think we have time for questions.
Yeah, great. Thank you, Dr. Cooch. We do have a lot of really great questions coming in. We are running a little short on time, but I think we have time for this really great one. So how do you track patients on treatment so you know to follow up with them after their 3-month kit?
That's a great question. Okay. And again, I would probably give you about 3 or 4 different options on how you might do that. But the way that we do it is we just pre-appoint them. If I know that I've got this patient, they've been on a 3-month kit, I've done the restorative, let's say we've done the restorative therapy in the first month, I've got either glass ionomer, we got the extractions, the root canals, you know, if we've got that extreme patient and we've got, you know, we're in the restorative care, I'm plugging holes in their teeth, I got them on the kit, I'm going to see them probably in a month just to pre-appoint them. You know, schedule, I need to see you for a 5-minute appointment or 10-minute appointment. I just want to check in with you for an office visit a month from now. And literally, if I've given them 3 months worth of materials, which I would have, I'm going to schedule a 3-month recall with them, maybe even to do a 3-month prophy, but certainly at the very minimum 3 months to see them in my chair, spend 10, 15 minutes with them. Let's go over how you're doing. Maybe I'm going to swab them again. Talk about if they're making behavioral changes, go through the coaching with them for it doesn't take long, just a few minutes, but then to give them another 3 months worth of materials and recognize that this is at a minimum a 9-month process, and maybe more realistically, this is like a 2-year process for patients. So just pre-appoint them for 3 months out. That's the easy thing. Yep.
Thank you. Thank you. And thank you, everyone, again, for all of your great questions. Again, any questions that were not answered will be answered via email within the next few days.
So do we have time for one more question, or are we...
Yeah, we can do one more question. So what's your recommendations for treatment of children under 6 with a high caries rate?
That's a really good question. I would certainly, following the ADA Council on Scientific Affairs guidelines, we know, and based on previous literature, we know that fluoride varnish is the best treatment outside of, whatever behavioral changes, whether that's dietary and home care that we can discuss with the, with the parents. As long as we've got those things in line and knowing what the risk factors are in terms of therapeutic strategies, eliminate the lesions that you can, and then I would look at fluoride varnish every 3 months. And I would tell you, in addition to that, you may want to consider the American Academy of Pediatric Dentistry's recommendation of using just a very tiny amount of standard fluoride toothpaste, 1,100 part per million dentifrice on those patients, recognizing that there's a risk for fluorosis, a minor risk for fluorosis, but the benefit in the research outweighs that risk. So there's kind of 2 recommendations I've given you there, depending on the patient, and I would discuss both of those with the parents and provide those as options and let the parents make that decision. But you can certainly make recommendations and give them options and, get the parents to participate. So great question.
Great, great. Thank you, Dr. Cooch. We really appreciate everybody's time tonight. Thank you for participating in this webinar. An email will be sent out tomorrow with a link to the recording for anyone who wants to share this webinar with their staff. And please, as Dr. Cooch said, please feel free to contact us with any questions, or if you'd like to learn more about implementing CAMBRA into your practice. We do offer those one-on-one webinars, and we'd be happy to schedule one to fit into your practice's schedule.
Well, good night, everybody. Thank you again for joining us. I know that the weather across the country has been a little extreme here in the last week or so, so I appreciate you being with us tonight. I wish you all a Merry Christmas and Happy Holiday Season and a prosperous New Year, and we'll be back together with you in 2014. Everybody have a safe travel tonight. Good night.